Okay, good afternoon, ladies and gentlemen, and distinguished colleague. Welcome to today's BrosMed webinar. My name is Hwan, a professor of radiology at Seoul National University Hospital and vice president of the Korean Society of Interventional Radiology. It is my great honor and privilege to serve as the chairman and moderator for today's session alongside my co-chair, Dr. Jorge Vilariño Rico from Spain. Dr. Vilariño, would you like to briefly introduce yourself as well?
Thank you, Professor Pham. Welcome. Good morning. Welcome to this fantastic webinar. I'm so delighted to be here with these great panelists. And let's move ahead. Thank you.
Okay. Today's webinar is centered on PTA strategies for PAD and AV fistula, practical insight and techniques. As endovascular interventions continuously evolve, sharing real-time clinical experience and technical tips is essential for optimizing patient outcomes in complex cases of peripheral arterial disease and AV fistula management. Today, we have gathered leading experts from across the region to share their valuable insights, case studies, and practical approaches. So, before we begin, let me briefly introduce our esteemed guest speakers who will be sharing their expertise with us today. Our first speaker is Professor Jung Kwak from Korea. Professor Kwak is an assistant professor in the Department of Radiology at Korea University, Annam Hospital. He is also an active member of the APS CBIR and Korean Society of Interventional Radiology and the Korean Society of Radiology. Next slide, please. Our second speaker is Dr. Pham Toan from Vietnam. Dr. Pham is an attending physician in the Department of General Surgery at Peripheral Hospital under the Ministry of Public Security. Next. Our third speaker is Dr. Tran Thoai from Vietnam. Dr. Tran is an interventionist in the Department of Cardiovascular Intervention at Hanoi Friendship Hospital. He has also been invited as a speaker at several major scientific meetings, including LINC, BICC, and Tanglong ICC. Our fourth speaker is Dr. Pywedont Mesakh Todingan from Indonesia. Dr. Todingan is a vascular specialist in the Department of Vascular Surgery at Siloam Hospital, Makassar. He is also a committee member of the legal and the post sector of PSPVI and has served as an invited speaker at the Celebes Vascular Conference from 2024 to 2026. Our final speaker is Dr. Anton Khilchuk from Russia. Dr. Khilchuk is a consultant interventional radiologist at Mesakh International Hospital in Tashkent, Uzbekistan. He is a member of several international professional societies, including SOCI, SIR, ESMINT, and the European Society of Cardiology. We are very fortunate to have such experienced and internationally diverse faculty with us today. On behalf of all the participants, I would like to sincerely thank our co-chair and all our guest speakers for joining us and sharing their valuable expertise. Now, let's begin our scientific program, and I will hand over the floor to my co-chair, Dr. Vilariño, to introduce our first speaker and lead the discussion for the first session. Dr. Vilariño, please.
Okay, thank you. Well, let's move to Korea again with the first session from today. It's PTA Strategies for PAD, Tri-Wedge Catheter for Stenosis in small caliber vessels with heavy calcification. Please, Dr. Kwak, you have the floor. Please go ahead.
Thank you for a kind introduction. Good morning and good afternoon, everyone. I'm Dr. Kwak from Korea University. Today, I would like to share my practical PTA strategies for PAD, focusing especially on the Tri-Wedge catheter for stenosis in small caliber vessel with heavy calcification. Let's start with a clinical case. A 64-year-old female presented with bilateral claudication that occurred after just 5 minutes of walking. She had a surgical history of a left femoral endarterectomy and a left popliteal artery stent placement at another institution. This is the initial CT scan. As you can see, there are multifocal significant steno-occlusive lesions with heavy calcification here and there. And the stent was occluded completely with distal reconstitution. On the reconstructed views, the severity is more obvious. We noted diffuse stenosis with heavy calcification in both legs. Also, the previously placed stent in the left popliteal artery showed complete in-stent restenosis and occlusion with distal reconstitution. For the left leg, our plan was to use endovascular atherectomy to debug the occluded stent, followed by draw-coated balloon. For the right leg, however, the vessel caliber and dense calcium required a different approach. Our plan was to use the Tri-Wedge balloon catheter for optimal vessel preparation, followed by a DCB. Starting with the left leg procedure, as we can see on the CT, the angiogram shows a complete occlusion of the stent. And distal reconstitution of the distal popliteal artery and relatively patent the tibial arteries. First, we successfully navigated the guide wire through the completely occluded left popliteal stent with effort. Here, we perform intervention to modify the in-stent restenosis to expand the lumen. We performed endovascular atherectomy with embolic protection device. And we used the high-pressure balloon for vessel preparation for in-stent restenosis and distal popliteal artery. Even with the proper vessel size for preparation, when I applied the DCB at the distal part of the stent, I noticed a small short segmental wasting at the stenosis vessel. So I used a Tri-Wedge catheter for more luminal gain. After the DCB and additional Tri-Wedge catheter, the final angiogram shows good recanalization of the occluded segment and good distal perfusion. Now moving to the right leg. The initial angiogram confirmed severe heavy calcification extending from the common femoral artery down to the proximal SFA. Initially, we attempted PTA using a standard high-pressure balloon. However, due to hard rock calcification, the response was not sufficient, and we could not achieve adequate balloon expansion. To overcome this, I switched to the Tri-Wedge catheter and Tri-Wedge effectively crack the dense calcium, allowing us to finally secure necessary luminal gain in the common femoral artery and SFA. Looking further down the right leg, we faced a long segmental steno-occlusive lesion with severe calcification. Navigating this anatomy is always challenging, but by carefully manipulating the 0.014-inch CTO wire, I successfully achieved true intraluminal passage across the entire disease segment. Even after this successful intraluminal wiring, we encountered another significant hurdle. The stenosis was so severely tight, the standard catheter and devices simply could not cross the lesion. To overcome this, we had to start a very small size balloon for initial pre-dilation. We then gradually upsizing the balloon step by step just to create enough luminous space for our subsequent devices to pass through. Following the step-by-step pre-dilation, we applied the DCB. However, the roadmap shows a somewhat suboptimal luminal gain at the popliteal segment, was leaving a significant residual stenosis. So, ideally, we would consider atherectomy to divert this resistance plaque, but the lack of the distal landing zone meant we could not safely deploy an embolic protection filter as left side, taking atherectomy completely off the table. Now, this would normally be perfect indication for intravascular lithotripsy, but since the IVL is not available option in South Korea, we need another highly effective tool to crack this tough calcium. Therefore, we concluded the Tri-Wedge catheter was our best and safe solution to effectively modify this stubborn lead segment. After applying the Tri-Wedge catheter to the resistant P2 segment, the result speaks for itself. Here is the final angiogram. We achieved an extremely satisfying angiographic outcomes with robust luminal gain and no flow-limiting dissections. Despite the severe calcification and the small vessel caliber, this strategy allowed us to completely restore optimal blood flow and all the way down to the distal runoff. To summarize, I would like to share my practical treatment algorithm for calcified PAD. Before dividing into the details, it is important to understanding our current clinical landscape in South Korea. IVL is not yet available because we don't have this option. We had to establish high effective and safe alternative strategies for tracking heavily calcified lesions, especially when distal embolic protection is impossible. This algorithm reflects that real-world challenge, I think. For common femoral artery calcification, surgical endarterectomy remains the primary option. If surgery is not feasible, we choose endovascular atherectomy, provide that distal filter protection is possible. However, without distal filter protection, the Tri-Wedge balloon catheter or fracking technique becomes our primary choice. Similarly, for SFA and popliteal artery steno-occlusive lesions, the decision relies heavily on the distal artery runoff. With a normal distal artery where filter placement is possible, we go with atherectomy followed by DCB. But if filter placement is unfeasible, using the Tri-Wedge balloon followed by DCB is our reliable and practical strategy to safe modify tough calcium. Thank you very much for your time and attention throughout this long presentation. I hope our real-world experience and this treatment algorithm will be helpful in your daily practice. I look forward to our discussion. Thank you.
Well, thank you. Great presentations. Please, I invite the audience. I think we have more than 800 people watching us right now. We invited send our questions. If there is no questions from the colleagues, from the panelists, I will like you to ask if you can talk us more about the Tri-Wedge balloon, because perhaps here people that's not familiarized with this balloon. This is like a cutting balloon. How do you use it? You have to rotate the balloon.
A Tri-Wedge catheter has 3 wires outside the balloon. The balloon may be a non-compliant balloon. So these wires help to break the calcium or plaque sufficiently. In my experience, it is more efficient than high pressure balloon. Just high pressure balloon, it is more efficient with wires. This is different from just cutting balloon. Cutting balloon has just 1 wire, and Tri-Wedge has 3 wires with 120 degrees at the 3 same angles at the whole circle.
Okay. I have some questions. What is the balloon inflation time when you are using a Tri-Wedge catheter? And another one is that, do you use Tri-Wedge catheter just for calcified femoral lesion or also for severely stenotic lesion in the femoral artery?
I inflate the Tri-Wedge catheter very, very slowly. I usually inflate 1 atmosphere, 10 seconds per 1 atmosphere, and maintain the pressure for 3 or 5 minutes, and deflate 5 seconds per 1 atmosphere. Very slowly inflation and very slowly deflation. Because it has wire, and I am wondering the wire can damage normal endothelium or normal vessel wall. So I try to take care when I perform the PTA using Tri-Wedge catheter. And this is in this presentation, my topic was heavily calcified lesions. So I showed you just calcified lesion that applying the Tri-Wedge catheter. Nowadays, I prefer this device to heavy stenosis or tight stenosis with just not calcified tissue, such as AVF or AVG with fibrotic restenosis.
Okay, thank you.
Great presentation. So my last question, Dr. Kwak, is do you see how do you plan the use of this balloon when you see a calcified lesion? Do you try to dilate first with POVA or something like that? And if you don't succeed, use this balloon? Or perhaps is there any scenario apart from the FBF fistula that you use it as a first-line treatment strategy? Thank you.
The first time I encountered this catheter, my strategy was first just POVA and then apply the Tri-Wedge catheter. But nowadays, I usually apply the Tri-Wedge catheter first at the heavy calcified lesion if the catheter can cross the lesion. If the Tri-Wedge catheter cannot cross the lesion, I use just 3 or 4 millimeter small balloon to pre-dilate the lesion and apply the Tri-Wedge catheter first.
Okay. Okay. Thank you, Dr. Kwak. And it's time for us to move on to our second presentation. And it's my pleasure to introduce Dr. Pham Toan from Vietnam. Today, he will present optimizing peripheral endovascular intervention, real-world experience with BrosMed peripheral solutions. Dr. Pham, please.
Thank you, Dr. Hwan and Dr. Jorge. And my name is Pham Toan. I'm working in 30 alcohol hospital in Vietnam. Today, I would like to share one challenge AVF after Stenosis case where correction balloon lastly was infection and how lesson preparation using Tri-Wedge cutting balloon facilitating success treatment with paraffin police. Yeah. And K1, K1st optimizing reverse resistant IVF after stenosis pattern profile and pattern information person 5 years old female chips complain left IVF after when stenosis past medical history and start renal diseases and on maintenance on dialysis hypertension treatment plan diagnostic fistulography and next and vascular balloon geoplasty of the stenosis lesion. Next lesson verification is Tri-Wedge scoring balloon flower by on optimization with a high pressure balloon which necessary final and geographic assessment of two coffin the vast luminal event and restoration of AVF flow. Like, yeah. Yes, next. In unity or geography and growth strategy. First, you just show by AVF set and sit in session. Next, there's no stick angiography and diffuse silver stenosis of outflow vein. First choice we use 035 guidewise crossing and not the file and choice 1 guidewise scoring crossing and we are successful and square trail lesson reduction and treatment. cohesion balloon angioplasty in nitrolation peroration and the lesson demonstrated characteristics characteristics of the resistant fibrotic stenosis in status of apply high rules. We decide to modify the lesson to the Tri-Wedge cutting balloon, separating balloon. Yes, interesting. And the scoring element focus the deletion for on the five degrees resting control like modification and vacating more affects special person in our experience this the study provide in self and more predictable upgrade for resistant AVF lesson. And after the quite lesson modification with the Tri-Wedge cutting balloon, scoring balloon, where pros fits with 6 and 100 mm PTA balloon, to optimize expression along the long distance segment. This sequential trajectory resume in a statutory angiographic outcome with restoration of AVF flow. Sequence in balloon angioplasty start in the resistant AVF stenosis, Tri-Wedge scoring balloon for lesson modification flow by paraffin PTA balloon of the optimal visual expansion. Okay. And second our second involves and 30 on 82 years old person operating with chronic limb ischemia, angiography reverse several stenosis of the left external iliac artery together with chronic obstruction of the superficial femoral artery. Give the nature of the diseases. That's the fact in the floor top the iliac artery were considered this first priority before us addressing this lesson. And in this process, the prophetic PTA balloon provide fast to lesson preparation across the long stenosis segment. The balloon, the mon started short variability and achieve satisfactory in the interluminal expansion and a towel as addition stand implantation were be required because of the persistent residual stenosis and other part visual peripheral peripheration with facilitated the subsequent intervention and put it into an excellent final angiographic result. And this 2K highlight in important price signal in the peripheral intervention. She is not single device at first every lesson. Yes, and in first case we are chatted resistant AVF outflow stenosis, and the lesson were fibrotic and difficult to expand. So lesson modification with the Tri-Wedge scoring balloon was an important first step. And after the Kwak periration, the paralyzed PTA balloon were with the active uniform vascular expansion and restored AVF flow. In the second case, the cellular were a long segment external iliac artery stenosis, and we are selected the teacher PTA balloon for initial lesson preparation of how the VCO and expand residual stenosis in Minh and a balloon expandable stent were implanted to achieve an optimal final result. These expense demonstrate to the group success the pin not only on the technical skill and but as well on the slick the appropriate device based on the lesson chat characteristics and shipment of legs. The right device use the right start of the health achieve self in intervention and better clinic outcome for our children. Conclusion. First, Tri-Wedge scoring balloon. The excellent vessel and gut government during scoring the balloon. The main stable without the blood thing of the sleeping the sensation of the expand with other scoring balloon. This provided better control, more uniform lesson modification and rest confidence when the treating reside in AVF stenosis. Reason excellent vessel were position not science stop scoring with minimal sleep pain. First, tip modification of fibrotic lesion, better procedure control, and second, teacher PTA balloon. We teacher just smoothly tall in long and third lesson. Balloon in lesson was uniform, providing excellent luminal and expansion without the need for excessive brochure. In the iliac lessons, satisfactory angiographic result, we are asked to achieve we are stand in implantation and smooth teacher PTA. We are feel smooth lesson processing and excellent course stability and trustability. Radius table balloon expansion effective vessel expansion without right standing and but at least PTA balloon but at
Dr.
least
Pham,
was
because of time limitation, actually, it's good for us to conclude here.
Yeah.
Okay. Thank you, Dr. Pham, for sharing your valuable real-world experience to us. And is there any comment or question for Dr. Pham from the audience and panels? Any question?
Yes, I have one question. Well, thank you for the presentation. We are short of time, but quick questions. How long did you inflate in the second case, the balloon, the tissue balloon in the external iliac to try to prevent dissection? How long do you inflate? 2 minutes, 3 minutes?
So inflation time for your second case, how long was that?
2 minutes.
2 minutes?
Okay.
Okay. Okay, it's time to move on to the next speaker. And Dr. Jorge, please.
Okay, it's a pleasure to introduce the next speaker. We're staying also in Vietnam with Dr. Tran, and he's going to explain us the mastering below the knee retrograde access for challenging SFA recanalization. Thank you, doctor. Please go ahead.
Nó nói giờ thịt nó luôn nhiều quá lỗi giờ mà nó tách nó nghe. In Vietnam, we have high population and high prevalence of cardiovascular and lower extremity arterial disease. Estimate the lower extremity arterial disease prevalence, I think maybe 6 to 8% in adults, and rapidly increasing with diabetes, hypertension, and smoking. Okay. So the reality, the patient come to hospital very late with severe COI, and of course with lung occlusion, heavy calcification. Although we have some new device like inverse rotation atherectomy, directional atherectomy, but in my mind, I think the access strategy is the key. In my practice, the standard you can see with the long lesion as the SFA. I try to punch as the same side femoral artery, and we use the 1/8 guide wire with the catheter support to growth lesion. After that, we use the balloon to pre-dilate the lesion. But sometimes we fail with the antegrade femoral. I use the addition distal SFA arm popliteal for retrograde assistance. After crossing, the treatment still via femoral access, but in many times we see some limitation. Total risk anatomy, difficult lesion access, inability to deliver device to the lesion due to bilateral common iliac artery stent. And of course, with two puncture sites at the SFA and popliteal, we can see more complication. The patient is discomfort, prolonged procedure, and higher radiation. This case with flush occlusion as the SFA, I try to cross lesion by CFA access first, but we fail. After that, I puncture at ATA access and I wiring from the retrograde. In this case, you can see I don't use the any catheter support. I use the Minerva balloon to support the guide wire to close the lesion. And after that, we do the pre-dilate and we up the side of the balloon to open the lesion. And we see this dissection as the X-ray, and we use the one stand. So the question why we can why we can do the retrograde tibial access to revascularization the SFA, because the tibial access is very nearby the lesion as the SFA, easier hemostasis comfortable, and with the retrograde the lesion is softer distal cap, easier true lumen entry, and of course we avoid groan, lower risk of peritoneal bleeding, but pseudo aneurysma. You can see the practice example. So in my practice, when I want to do the total retrograde, I use my protocol is the first step. We use single access as the ATA or PTA by ultrasound guidance. After that, we insert 6 Francis. Step 2, we retrograde first crossing with support catheter or balloon catheter like the Minerva, and crossing from the below. And the final on the therapy via tibia, POBA, DCB, stand, and of course, if need, I ask the antegrade wire for guidance, but on the device via tibia. And of course, in my practice, I do more than 50 cases, that's B, 2D, and 100% technique success with no major complication. And I think the important is we can do the retrograde puncture under ultrasound, and we must use the lower profile device ecosystem with high checkability, like the Minerva balloon. And of course, in many cases, we must use Tri-Wedge. So now I want to show some case. The first case with the long lesion at the SFA, I puncture at the PTA, and I wiring from retrograde to gross lesion with the Minerva 4 mm balloon to support the catheter. After that, we pull back the guide wire and we check the angiography through the balloon catheter. After that, we do the pre-dilate and we up the size of the balloon to retrograde to dilate the lesion. And finally, I use the short stand to put at the FFA with more dissection. The second case, you can see the long lesion in on the length of the SFA. I puncture ATA, then I wiring with a 1/8 guide wire and a Minerva balloon to support the guide wire. After that, we use a bigger balloon to open the vessel, but recoiling, and I used the Tri-Wedge 6 mm to open the lesion. After that, I check my angiography. So, conclusion, I think the first complex femoral popliteal CTO remain a challenge, particularly in patients presenting with advanced disease. A total retrograde strategy via single tibial access is a feasible, safe, and effective approach, achieving high procedure success with reduced procedure time, radiation exposure, and excellent patient outcomes. Adequate lesion preparation with the Tri-Wedge scoring balloon, followed by Minerva and Atropos PTA balloons, facilitate successful revascularization in this complex case. And the hydrophilic coating of the Tri-Wedge scoring balloon provide excellent checkability and smooth recrossability, allowing repeat inflation without increased friction or delivery resistance. And I have a question for the expert. As a young physician, I would like to ask, so should the total retrograde be considered a first line approach for complex femoral popliteal CTO? Thank you so much.
Thank you. Thank you for your fantastic presentation. I think this is a point and question. I have doubts. I do a lot of endovascular treatment below the knee and SFA, and most of the time, the very, very complex cases, you have the bilateral approach. Because if you want to do a cart or reverse cart or something, you need 2 wires. But of course, this is a great tool, a great technique, the total approach. And I have one question. How do you close the puncture? If you use a 6 French sheath in a tibial puncture, how do you close it? Just compression? Because most of the time, we do an endo clamp with the balloon from the antegrade. So how do you do it? Thank you.
Thank you so much for your question. In many cases, I think with tibial access, I usually use the compression manual.
Okay.
Because when I want to puncture at the below the knee, I must check ultrasound first. I try the position with the ATA or PTA to puncture, and of course I try to avoid to risk vascular. So I think compression manual is very effective in this case. Thank you.
And normally, what level do you puncture? In the foot, or do you go to the below the knee, like the third portion of the popliteal artery, or perhaps the most accessible way, the most proximal part of the tibial arteries? What level do you puncture, treating the SFA?
When revascularization SFA in ATA, I puncture with ATA, I puncture near the knee, and
Okay.
PTA, I puncture. Yes.
Just one more comment. In our hospital, when we make a lateral tibial access, we just insert small wire or small wire plus micro catheter. So main devices such as large balloon or other things are inserted from the femoral side access. So we use only tiny small guide wire or micro catheter from tibial access. So I think that using 6 branches in the tibial artery is too big, and it can make some problem later. So I don't recommend using 6 branches in the tibial artery.
I know. I
It's my opinion.
agree. Yeah. So when I want to do this technique, I must check the size of the vessel. The size of the vessel is more than 2.5 mm. So I insert the sequence in the big vessel. And in many case with complex case and the long lesion as that way and the BTK vessel, I think we can do this technique. So the first is we have the health vessel as the BTK, and the size of the vessel, I think more than on 2.5 mm.
Okay, I see. Okay. It's time to move on to next speaker. And our next speaker is Dr. Pywedont Mesakh Todingan from Indonesia. And he will present his clinical experience with the Tiki balloon in CLTI and central venous or drain vein stenosis. Dr. Todingan, please.
Thank you, Doctor. Thank you, Prof. Good afternoon, Professor, Doctor, everyone. Thank you. Let me introduce myself. My name is Pywedont Mesakh Todingan. I am a vascular and endovascular surgeon from Indonesia. I live in Makassar, South Sulawesi. Today, I will present about Tiki balloon in a patient diagnosed with CLTI and central venous stenosis or draining vein in end-stage renal disease patient. The first case is about chronic limb-threatening ischemia. It's the first patient, male, 72 years old. He felt pain for 4 weeks at the left foot and non-healing wound on the left foot. He felt constant burning pain, and he felt constant and burning pain in the left foot. He has underwent a debridement at another hospital 2 weeks prior to admission, but the ulcer became worse. And then the second, third, and fourth toe developed dry gangrene with no sign of healing. The claudication, he felt pain at the calf for 1 year, but patient ignored it. The risk factor, patient has diabetes, hypertension, and dyslipidemia, and he is an active smoker also. From physical examination, the blood pressure is higher, and the vascular examination, we can see there is ischemic ulcer on dorsum, plantar foot, and the two second, third, and fourth two with gangrenous tissue in the left foot. We diagnosis with CLTI, Rutherford category 5, with classification, bone grade 2, ischemia grade 2, foot infection grade 2. And this is from the angiography of the vascular flow of the patient. Yes, we see the anterior tibialis artery, the stenosis, the posterior tibialis artery is multiple stenosis 2, and the peroneal artery is multiple stenosis 2 until Pywedont. We see in peroneal and posterior tibial artery, like the arrows, we see the multiple stenosis until the anterior tibial artery is the worst severe stenosis in anterior tibial artery. And we use two balloons. The first balloon, teacher 3 millimeter, we use in the anterior tibialis artery, peroneal artery, and posterior tibial artery from the distal of foot until the proximal. We use the second balloon, teacher 6 millimeter, in superficial femoral artery 2. And this is the final angioplasty. We see the vascular flow seamlessly to the distal, especially in anterior, which is the worst stenosis. It can open, but sorry, it cannot complete open in anterior tibialis artery, but in the tibialis posterior tibialis artery and peroneal tibialis artery is open until the distal. This is the wound after 2 weeks after the operation. Yes, the most important thing, we can save the patient limb, and we don't have to amputate below the knee. Yes, we did amputate the second, third, and fourth two, but the future, the patient can still has the ability to walk. This is before, and this is after we use the tissue balloon. The second patient is about central venous stenosis and draining vein stenosis in end-stage renal disease. The patient, male, 62 years old, he presented with edema of the left upper arm and lower arm for 5 months. Persistently elevated venous pressure during dialysis, prolonged bleeding from needle puncture site after treatment. He also experienced poor blood flow rates, recirculation issues, and recurrent thrombosis of the AV access. We see the unilateral swelling at the left arm affecting the access arm, shoulder, neck, and face. We see the stenosis in draining vein or vena cephalic, and until cephalic vein, ciliary vein, until the innominate vein. We use two balloon too. We use first balloon, teacher 6 millimeter. 6 millimeter, the balloon in draining vein or vena or cephalic vein. And this is the video of stenosis of innominate vein or central veins. In innominate vein, we use teacher 10 millimeter. And this is the after we use teacher balloon, you can see the vascular flow seamlessly going from draining vein to innominate vein. The patient is mild and the udem is become smaller. Conclusion, teacher is effective for treatment of mild stenosis. However, total occlusion requires the use of cutting balloon. Teacher is safe and effective treatment modality for chronic limb-threatening ischemic and vein stenosis in patients with renal stage disease. Thank you, Professor and Doctor.
Thank you, Dr. Todingan, for your interesting presentation and for sharing your cases. I have a quick question. What is your preferred balloon inflation time for BTK interventions, and what is your balloon inflation time for central venous stenosis?
The time I balloon in PTA 1 until 2 minutes, and then 2 minute pain is same 1 until 2 minutes.
1 to 2 minutes for BTK and central vein. Okay. Just one time or twice to third time?
Actually, two until 3 times.
2 or 3 times. 1 to 2 minutes and 2 or 3 times. Okay. Any other comments from the audience?
I think that we can move to the next presentation.
Okay, good.
Yeah, I think it's my this is the last presentation. Last but not least, it's a pleasure we are moving eastwards with Dr. Anton Khilchuk, and he's going to explain us the great strategy, the simplifying tibial recanalization one balloon pedal arc crossover strategy. Thank you, doctor. Please share your presentation.
Thank you, muchas gracias. I want to thank a lot of our speakers for the great presentation, a lot of complex and challenging cases. Let me share my presentation, in which I will be focusing on the one aspect of using the dedicated product from BrosMed Medical, which I'm happy to use for more than 3 years. So I will talk about the simplifying tibial recanalization with the one balloon pedal arch with the swing and crossover. And so this lovely child is how I feel always when crossing the lesion when doing the intervention on the pedal arch. So I will just take a few moments to emphasize the burden of atherosclerotic disease, of the peripheral artery disease. You can see that more than 200 million people affected globally, and you can see the tip of the iceberg, which we see with the visible disease, the symptomatic PAD, the intermittent claudication, the rest pain, but you can see the what is below the surface, like the silent presentation, all the cardiovascular risks. So we're dealing with the really, really big problem. And as in vascular and endovascular surgeons, we primarily deal with the peripheral arteries, with the tibials, with the popliteals, SFAs, with the inguinal, below the inguinal ligament, above. Like the importance of our intervention is cannot be stressed more. So let me show the cases. Let's start with the quick case, with the most uncomplicated one. You can see the Wi-Fi 320 classification on this patient. You can see the necrotic left pinky on his foot and high level of ischemia. You can see the level of ischemia also at his toes. So I can tell you that from my perspective, for more than 3 years using the BrosMed, the Pollux became the balloon of choice for me, and I can proudly say that to the company because I will start every intervention. I will try to start it with the Pollux. Sometimes the lesion is too hard. The softness of Pollux couldn't allow me to advance. I will take the other dedicated balloons, but it's always like the first choice for me. And for that patient, it went smoothly, absolutely, to the pedal arch, and then navigated through the arch, navigated through the lateral plantar artery, and navigated into the posterior tibial from the anterior, from the arch, from the foot. And with the Pollux, like as a balloon of choice, personally, I can do almost all intervention with only the Pollux. Sometimes, because of this hydrophility, because of this softness, I can cross the arch, I can cross the plantar. The plantar, I can go either from posterior to anterior or from anterior to posterior, and I really like it. And almost always, I'm able to do that. With the Pollux, you can see the advancement. You can see balloon is here in the anterior, and then to the plantar arch, and then to the posterior tibial, and then we did almost all intervention with the only with the Pollux. But of course, it's a semi-compliant or compliant balloon, so we then use the Castor one to finish if we need to. But sometimes, like maybe 30% of all cases, we can finish only with the Pollux with two different diameters, like 2 millimeter for the plantar arch for the foot, 2.5 or 3 millimeters for the tibials. And you can see how far it can go easily, absolutely. Sometimes when I do not have some sizes of Pollux, I can take the dedicated from the major vendors, you all know them. I can take them. They will cross the lesion, they will go to the plantar arch, but they cannot, sometimes they cannot, and almost always they cannot advance as far as can go Pollux. So thank you, BrosMed, for that. And you can see the final result only with the Pollux, this case only with the Pollux. And you see the result. And with this strategy using only Pollux, we were managed to do the intervention under 30 minutes with only 50 mLs of contrast media. You can see the result. There is almost result ischemia. There will be a necrosis here, and there will be a necrectomy here. So the second case, a little bit more complex with the Wi-Fi. You can see 1, 2, 1. The moderate risk of amputation, high benefit of vascularization, full occlusion of SFA, and a lot of plaque burden in the tibials and in the foot. So it was like relatively straightforward case with the SFA using Atropos, and then using Hermes, and then using the laser cut nitinol stent, finishing with that because obviously it was heavily dissected and really ugly. Then it seemed that relatively easy or more moderate tibials, but antegrade approach failed. We switched to retrograde. We do this routinely either as a first choice or as a second choice or the third choice or as a plain D or plain V. And then we were able to finish the recanalization of the lesion, to do all the preparation, all the balloon angioplasty, and finish the case with the anterior tibial and plantar arch. So you can see the sorry, there would not be a result for that case. I didn't save this just to show you. This is the third case. You can see the almost no wound, but heavy ischemia in this poor patient. A moderate risk of amputation still, but high benefit of vascularization. And the patient have multi-stage atherosclerosis, multi-level atherosclerosis from the inguinals to popliteal to tibials. I can return to that. And we had to do the synthetic bypass below the knee because even on the upper extremity he didn't have any sufficient veins to do this long bypass. He was a really hard patient. And unfortunately, we did the synthetic, but still it was necessary for this patient. So we did a balloon angioplasty with the then after the bypass we did the balloon angioplasty. You can see the let's see, yes, you can see that we are crossing the lesion. We can we're crossing the plantar arch, doing what we must, crossing relatively easily, considering the amount of plaque burden. You can see how smoothly pollux can advance further and even further and even further. And you can see the loop technique. It went smoothly, so we didn't cross to any type of recognition. Then we managed to cross to the bypass and did every step with the tibials. And I want to stress that. I want to show you how we try to do also the atherectomy from the tibials, if it's possible, through the access to allow us to enter. Sometimes we'll have some difficulties going under the intima or in this rupture plaque, but almost always we were able to do that and to cross only with the one balloon. You can see the loop. And then this is a whole loop. This is a whole swing, and we're doing one balloon from, in this case, anterior tibial. So we do the balloon angioplasty. You can see the final result, and this is this particular step was done only with the pollux. Of course, we finish with caster, and that's why I call it a swing, because you just putting the whole leg on your wire swing and doing the whole intervention with the pollux, then finishing with caster, or almost always we do that. You can see the intervention at the end, only under 25 minutes, and my team from Uzbekistan right now are routinely using the BrosMed balloons. So just to be quick, I want to finish with peripheral, to stress that in peripheral vascularization, it's important to know your instruments and disposables. Pollux is personally is always my first choice. You need to select a strategy tailored to each specific patient. Either it's open end or hybrid, one balloon, two balloon, three balloons, the Tri-Wedge, the cutting balloons, and not to be afraid to take the most complex cases. And thank you for your attention.
Thank you. Great presentation, great cases, especially the third one. And just want you to explain us how important is for you the compliance of the balloon, non-compliant versus semi or compliant, because you told us that you use the pollux normally, and 30% of the cases you have to change the caster for the final dilation. Did I get it right, or how's it?
I want to say that 30% of cases we finish only with pollux, with a relatively soft plaques, and almost always, like the majority of cases, we need to switch the non-compliant balloons, like caster, obviously, and or use some cutting balloons. But yeah, like 1/3 of cases we can use just the pollux type of balloon with different diameters. We still I can distinguish like it's just two different kinds of balloons. Pollux is a relatively soft to cross the lesion to go through the loop to do the primary intervention, and then we need to switch to non-compliant. Sometimes it can be coronary balloon if the lesion is like really non-crossable. Sometimes we can take the non-compliant or super soft coronary balloon just to open the plaque and then switch to Pollux again, then switch to non-compliant balloon. So we totally do this. We try to escalate as much as we could, but only in a selected patient.
Okay. If there is any question from the audience, I think we are on time. We have to, Professor Hwan, I think we have to conclude the session. Well, it was a great session, great panelists. Thank you all for your efforts, for your great presentations. I think these three things stand out from this webinar. First of all, the importance of sharing knowledge with all over the world, your real world experience from Russia, Indonesia, Vietnam, and Korea. It's a pleasure to have you all here. Second, I think most of you conclude that there's no one size fits all for the patients. We have to choose the right material, the right technique, and of course, always with the aim, with the goal of the improving patients in our minds. And third, I would like to thank BrosMed Medical for this great initiative, this great effort. I think today it's very clear that you have a very broad portfolio, and we can treat a lot of our patients. So, Professor Hwan, if you want to say some words to finish. I think you have to unmute your. We cannot hear you.
So sorry. I would like to sincerely thank our speakers for their valuable presentation and all participants for joining us. And many thanks as well to BrosMed for organizing and supporting this educational program. And it has been an informative and enjoyable session. And thank you once again. And I wish you all a pleasant day. Thank you.
Thank you.
Thank you.
Thank you very much. Have a nice day.